Alright guys, we're back. One last video, hopefully. We'll get right into this. We're jumping back into transfusion medicine. So here's some of the transfusion products that you can use. So whole blood, not as commonly used as packed red blood cells. So whole blood contains RBCs and volume, volume meaning plasma. So you can use that in actively bleeding platelet patients who have lost like a huge amount of blood volume. So you're not really giving them saline and packed RBCs. You're just giving them whole blood. Packed RBCs are more commonly used for anemia. Always transfuse for hemoglobin less than 6. Most of the time, people with hemoglobin less than 8, you will actually transfuse, but it's kind of like a soft guideline. And you never transfuse for a hemoglobin over 10. So getting platelets. So you mainly do that for very extreme thrombocytopenia or if they need surgery. So then, and if they have renal failure, so renal failure also affects platelet function. Uremic platelets don't work very well. So if they have thrombocytopenia below 20, you're also going to want to give them platelets because they're at the same high bleeding risk. You also want to replace platelets in people who have qualitative platelet defects. FFP, so that has coag factors. You can give it in DIC and cirrhosis. You want to. It also can be used with warfarin overdose to rapidly replace all the factors in cases where vitamin K is not going to be fast enough. Cryoprecipitate differs from FFP in that it contains fibrinogen, levels of fibrinogen, and so you can use that in coagulation factor defects. More transfusion products. So for when you're transfusing this is for mainly red cells, but it can affect, obviously being anything, platelets, etc. Leukocyte reduce, so that you send the product through a filter. It prevents platelet alloimmunization. So as you know, white cells have both HLA, MHC class 1 and MHC class 2. You require both of those to induce alloimmunization. Platelets only have MHC class 1 HLA antigens. But so by themselves, just having platelets won't cause alloimmunization, but having the white cells will. So leukocyte reduced reduces that risk. Can also, if you have recurrent febrile non-hemolytic transfusion reactions, so kind of reactions to like the cytokines in the white cells, you can also use leukocyte reduced products. CMV negative is important in your transplant patients and people who are immunocompromised for other reasons, have immunodeficiencies. Just make sure that it doesn't have CMV. Irradiated is even more than leukocyte reduced. It completely eliminates lymphocytes, prevents graft versus host disease, which is a T-cell mediated disease, and is important for people who undergo bone marrow transplant or are severely immunocompromised. So here's a kind of table of all the reactions. Touch briefly on a few of these. I don't want to read for you. Make sure you understand like these presentations is what I'm mostly going to go through. Allergic reactions. These are very common. They're not super dangerous. They don't prevent you from giving more products. Just make sure you give them Benadryl and maybe steroids if they're having this. You want to differentiate that from two other common or two other presentations. One being the anaphylactic, so that is due to usually IgA deficiency. You have to use IgA deficient blood products to prevent it, but they're going to have severe dyspnea, hypotension, right? They're going to be an anaphylactic, distributive shock, and bronchospasm and respiratory arrest. So these people are looking really bad. You differentiate allergic from febrile non-hemolytic in that the absence of rash. So people can get a fever, they'll be flushed, they may be a little bit red, may think it's an allergic reaction, but really look for those hives and itching and wheezing. But for febrile non-hemolytic reactions, you can just give them some Tylenol, just observe them, prevent it in the future by using the leukocyte-reduced products. Hemolytic means they're really sick. Their Foley bag turns brown. They're hypotensive. They're in shock. They're in pain. They have a fever. It's really bad, and it's because someone goofed and gave them the wrong bag of blood. Usually, scanned the wrong tag or something like that. Graft versus host, so that's T-cell lymphocytes in the blood that you're giving them attack a very vulnerable immunosuppressed host, most commonly in a bone marrow transplant, and it attacks all your organs. It can attack your liver, your bone marrow, your GI tract. It can be very, very severe, and you need to prevent that by irradiating blood products to completely destroy all lymphocytes. Charlie, basically, you get ARDS from a transfusion. It's caused by a donor antibody reacts with neutrophils and causes damage to the pulmonary endothelium. So basically, you get the kind of bilateral infiltrate and very low PaO2 to FiO2 ratio, PF ratio. That's kind of the definition of ARDS. So moving on a little bit to cancer. So we're going to do a brief cancer overview of some of the leukemias. So this is stuff from your lecture, how you make the diagnosis of cancer. So starting from a bird's eye view, cytogenetics requires a long time to do. You can see large translocation, like you can see up here the 922 Philadelphia chromosome here. You can see large differences that you may not actually see on a PCR because it's translocation and all of the gene is there, but it's kind of a quick eagle's eye view, if you will. A fish has better resolution. You can use targeted probes for specific abnormalities. Like over here, you can see like the HER2 expression. In the middle here, you can see increased HER2 expression in breast cancers. And it's a quicker test. You can, after the cancer is defined, then you can use it to assess response as well, because you know what you're looking for. So we're going to be talking a little bit about AML, myelodysplastic syndrome. So remember, they can be cytogenetically normal. So that means that you do a karyotype and you do a FISH and it looks normal. That doesn't mean it's genetically normal. So all cancers come from oncogenic and tumor suppressing mutations. We just may not be able to identify what exactly that mutation is. So Sanger sequencing is the old-fashioned slow way of sequencing. Now we use next-gen sequencing, which is a lot faster and easier to do. You can use a whole genome approach, which may not always be the best approach because, we don't know what everything means. So you may find a lot of abnormalities and differences that may not actually be significant. So most of the time, people are trying to get smaller and smaller targeted panels for specific genes that we know are abnormal. Gene expression profiling, mentioned in lecture, is not used as much for specific things that we know that are overexpressed, like HER2 in breast cancer. You can use it, but it's not as common. Chromosomal microarray, so that's similar, kind of looks broadly to see various sites of expression, but doesn't see balanced translocations again, because remember, all the genetic material is there for translocations. It's not used as much. It's just to emphasize also in lecture that, remember, after you treat a leukemia, you need to kind of repeat and assess your response to see if these abnormalities that you've detected have regressed. So moving on to bone marrow disorders. Congenital, you have Fanconi anemia, which is actually a pancytopenia, and you can see just You're going to have to memorize these abnormalities here. Diamond-Blackfan, it was a macrocytic anemia. Schwachman-Diamond is neutropenia associated with pancreatic insufficiency. Dyskeratosis congenita, not really in first aid, causes pancytopenia and bone marrow failure, as well as skin abnormalities. Aplastic anemia, really a pancytopenia. So aplastic anemia can be caused by many things. True aplastic anemia is autoimmune aplastic anemia. It's T-cell mediated. It tends to be in younger patients, and you see on the bone marrow biopsy this fatty infiltrate. There's really no precursor cells in here. It's just empty, and you treat it with immunosuppression. Once you've ruled out these other potential causes, you use anti-thymocyte globulin. Remember, it's T-cell mediated to allow your counts to recover. Leukemia, just an overview. Disruption of cell maturation. You get all these blast cells. You get very high white count. You divide it into acute and chronic, and then we divide it further into what type of cell it is. Leukemia has, these are very sick patients. For the acute leukemias, come in with bone pain due to expansion of the marrow, fatigue, shortness of breath due to anemia, hemorrhage, and affecting all sorts of different kinds of organs too. So AML is usually in older adults. The important subtype associated with step 1 is M3 AML with the Auer rods, which are precipitated myeloperoxidase, which are these little pink rods that you see in the cytoplasm. Very severe, very sick patients. Risk factors include having previous chemotherapy or radiation, benzene. Myelodysplastic syndrome can progress as well to AML. Down syndrome is also a risk factor. You get worse prognosis in people with trisomy 7 who present with very high white counts. And if you have MDS and it becomes AML, that also is a really bad prognosis. So you can see here, then just a picture of these Auer rods in here. Classic. All right, MDS. So that's basically any sort of ineffective production of myeloid cells. You can get pancytopenia, you get macrocytosis. Remember, immature red cells are larger. You can get splenomegaly as well. One of the things you can see in MDS is the pseudo-Pelger-Hewitt. Remember, Pelger-Hewitt is this kind of bilobed neutrophil with a thin bridge in between it. You can see that as a congenital thing. Pseudo-Pelger-Hewitt means it's from MDS. Giant platelets you can also see on the peripheral smear due to bone marrow affecting the maturation in the bone marrow. You treat it with chemo. It's graded. Lower grade is less than 5% blast, which is normal. Leukemia means it's greater than 20% blast in the marrow. High grade is 5 to 19%. So you do the bone marrow tap. You kind of assess what sort of genetic markers there are. Is this an MDS? Is this a leukemia? And you kind of grade it from there and treat it with chemo if it's bad enough. AOL, there's B cell and there's T cell. T cell is more commonly in teens. B cell is in younger kids, age 2 to 10. AOL is more common in kids overall. So all ALL lymphocytes are TDT positive. So that's in lymphoblasts, it's pre-B and pre-T. There's other specific markers in B and T cell, so B cell CD10, 1920, and T cell is 2 to 10. T cell in general is associated with thymic mass and a worse prognosis. I'll let you read about the treatment here of B cell ALL. These are just some pictures of a acute B cell ALL here. CML, older adults, BCR-ABL fusion, basophilia. It can progress to AML overall, and a low LAP score differentiate from leukemoid reaction.